So, as I say, I do feel humbled coming back up north because I owe the north everything that I have. And when, having spent 10 years in Sheffield as the founding chair of urology, which is a huge privilege, having set up the academic department of urology there, when Oxford called and asked me whether I was interested in the Nuffield Chair of Surgery, what I said is, "You must be joking." And they said, "Why?" I said, "Well, do you know who I am?" And I said, "We think we do." And I said, "Well, listen, I'm a urologist. I've always worked in the north of England, and I can't even speak English properly, and you want me to come to Oxford?" But after a lot of debate and discussions, I was absolutely convinced that it was a fantastic opportunity, and I did go. I've been there now 3 years, and it's a wonderful adventure. So I do bring you greetings from there. This is just to remind you what I do. I check people's prostate. I'm still very much an active clinician, and I operate and I remove prostate, sometimes with difficulties. As you can see here, I had lost my trousers, and it was quickly snapped by a nurse. This was actually in Sheffield at Lodge Moor, working with David Thomas. And I do this half of the time, and the other half I think, and if you haven't recognized me, I'm on the right-hand side of the screen. Now, some of you know me well, but others don't, and before you ask, why is it that we have somebody who technically is an Oxford Don who can't speak or speaks funny English and doesn't look like an Oxford Don? And that's the reason, because this is where I was born, on the shores of the Mediterranean in Alexandria, and this is where my parents and grandparents came from, and then in 1982 I left and I went to France, spent a year. Then after that I came to England, and I did, after qualifying from the University of Alexandria in Egypt, I did all my surgical postgraduate training in the UK since 1983. This is where I did my house jobs. This is the shores of the Nile. This was a pediatric orthopedic clinic which I used to run there. This was the staff, and this was my transport at the time. This is in 1980 and 1981. I keep extremely fond memories of that, and when people complain about the NHS, I always think of my days as a student, medical student, and I tell people how privileged we are in the West to have the healthcare that we have. In England, I moved steadily from north to south, Newcastle, Sheffield, Newcastle, and back down, with a spell in Mansfield for 1 year, where I had the privilege of meeting John and Barry and others. I kept moving south, and I have to be careful because every time it's exactly 130 miles, and the next time I jump, I'm going to be in the middle of the channel. I went to Oxford, and I said, "Oh my God, what have I done? Why have I left all my friends, all the good people I knew, nice setup I had? Why did I come to Oxford?" And my house is still on the market. We haven't sold it. So if anybody's interested, please talk to me afterwards. But Oxford has been wonderful and continues to be wonderful. This is where I have dinner every evening. I'm a fellow of Balliol College. It's not true, I don't go very often. It's just been an extraordinary privilege to be there, and continues to be very exciting. So, prostate cancer. Now, I don't want to offend anyone who knows where the prostate is, but in case anyone doesn't know where it is, that's the anatomy. It's a deep-seated organ in the pelvis, which is very difficult to reach technically and surgically, and it's very challenging to do surgery on the prostate because of important functional outcomes such as continence and erectile function. And the problem we have with prostate cancer is on that slide. And this is not a mistake because I make all my slides, but for the gentleman in the audience, if you are able to read what it says, then you don't have to worry about prostate cancer. But you can't, and I can't. And this is what it says. As the eyes grow dim, the trunk bends, the cartilages ossify, and the arteries change in their coat, so the prostate is supposed to grow large and hard. 150 years ago by a physician called James Miller. And what it says is what we know now. Prostate cancer is very common and is part of aging. The problem we have with prostate cancer is the incidence mortality ratio. You can see lots of bars here in this histogram. The dark blue bars represent mortality. The light blue represent incidence. So if you go to the third world, Asia, Africa, you can see that, and the Middle East, you can see that the bars are more or less the same. As you go towards the West, particularly in the US and North America, you can see the incidence bar are far bigger than the mortality bars. So immediately what that tells you is that there are more patients who are diagnosed with prostate cancer than patients who die from prostate cancer, which again we knew. But there is another side of prostate cancer, and it continues to kill patients. So I want to read with you this wonderful statement by Benjamin Brodie, 1842, in Old Flowery English, which we don't use, unfortunately, anymore. And it says, "We found the patient complaining of excruciating pain in various parts of the body." So these are pain from metastases, which could be compared to nothing except pains under which persons affected with carcinoma occasionally labor. He could void no urine without the assistance of a catheter, outflow obstruction. The prostate gland examined by the rectum was found to be much enlarged and of stony hardness, sometimes the only sign of advanced prostate cancer that we find. I continued to visit him for nearly a year, at the end of which time he suddenly lost the use of the muscles of his lower limbs, paraplegia due to spinal compression, sometimes caused by androgen suppression also, iatrogenic, causing osteoporosis and skeletal metastasis, and died a fortnight afterwards, usually from renal failure because both ureters are affected. We still see patients with prostate cancer who die like this in the 21st century. And if we look at the biology of prostate cancer, this is what we have. It starts with a normal glandular epithelium. At some point, there is histological prostate cancer, which may be of no significance whatsoever. And at some point, there is a switch, and this histological prostate cancer becomes clinically significant, then locally advanced, then metastatic, and finally, all patients, or most patients, die of castration-resistant disease. Now, we know through studies using 5-alpha reductase inhibition that we can prevent the diagnosis of prostate cancer, but do we know who to give the chemoprevention to? And there is no answer to that. It would be massive over-treatment of men in their 40s and 50s with a drug that perhaps is not helping them. We know that we can cure prostate cancer. We can remove it, we can irradiate it, we can freeze it, we can heat it, we can put radioactive seeds, but we don't always know whether we need to treat the patient, or are we over-treating him, or indeed under-treating him. We know how to palliate, and it's something that has improved considerably. When I was a registrar in urology, and it's not that many years ago, when a patient presented with castration-resistant disease, we knew he had 6 to 9 months to live. Now, the average is probably 3 or 4 years. So there's been a lot of improvement in palliation in patients with castration-resistant disease. Now, screening is very, very controversial, and not just in prostate cancer, but you all know, for example, that breast cancer is being questioned now. And there's a very large review which has been commissioned by Mike Richards to look at the evidence behind the introduction of breast cancer screening in the UK, and this is ongoing. Screening is very old. This is an illuminated manuscript from the 12th century from the Netherlands, and what you can see is a Benedictine monk and a Benedictine nun, and this is a digital rectal examination doing with a knee-elbow position, which we don't do anymore. It hasn't changed very much, except in this country we do it left lateral now, and they're not Benedictine monks. What's happened in the 1980s is 2 things which are very, very interesting. First of all, prostate-specific antigen was discovered and entered into clinical use, and anatomical radical prostatectomy was developed. In other words, removing the prostate with acceptable functional outcomes, which did not happen before, and that was brought in through the study and the knowledge of anatomy pioneered by a Belgian anatomist together with Pat Walsh, a famous urologist at Johns Hopkins, who has now retired. And these two things together created a climate where many, many prostate cancers were detected and many, many prostate cancers were treated. And some of you remember Jeff Chisholm, who was a urologist and was professor of surgery at the University of Edinburgh. And at that time, when PSA started to be used widely, when radical prostatectomy started to increase in rate, particularly in North America and Northern Europe, but not in the UK, he wrote a wonderful editorial in 1993 in the British Journal of Urology, and I will read with you what he said, because it was very inspiring. He said, "There is now the prospect of a prostatectomy holocaust, unless acceptable data can resolve this debate, and all of this is the result of a seemingly simple blood test." And this is absolutely true. There's a very famous biologist, scientist, who spent his life studying prostate cancer called Don Coffey at Hopkins. And I heard Don Coffey say one day in public with all the urologists, North American urologists, say, "Gentlemen, you are not treating prostate cancer. You are harvesting prostates." And this reflects exactly what Chisholm was saying there. The second statement he made in that editorial, which was particularly inspiring to me and to many of my colleagues and at the time, was it must be clear that this debate cannot be resolved because there has never been an appropriate trial either of screening or radical surgery or no immediate treatment. There was no evidence from any randomized trials that testing for prostate cancer, that treating prostate cancer made any difference to mortality from the disease or overall mortality. Indeed, until randomized trials are performed, we will not know if early detection, with or without radical treatment, improves cancer-specific survival. Unfortunately, Chisholm died prematurely. He died a year later after writing this editorial, and he has not seen his predictions come alive, and how inspiring he has been for us. Now, does prostate cancer screening reduce mortality from prostate cancer? And these are very interesting figures, looking at a period of 30 years, comparing the US with England and Wales. And if you see here the top curve, this is the incidence of prostate cancer in the US, and this is the incidence of prostate cancer in England over these 3 decades. And what you can see is that in the US, in the late 80s, PSA was taken up, lots of men were diagnosed, there was a huge backlog of men with insignificant disease who were being diagnosed, and this is now coming down because the backlog is gone. In England, PSA was not taken up, and compared now with the US, with Northern Europe, we are still very, very conservative, and I think this is probably because of the very British conservative attitude towards not doing something unless we have good evidence behind it. And we are running now at a rate of about 10% PSA testing in the age range 50 to 75, compared to 75 or 80% in the US, 75% in Germany and Northern Europe, and almost 90% in France. Now, if you look at mortality, it becomes even more interesting. The mortality from prostate cancer started to decline in the US in the mid-90s. And the North Americans then started to say, well, we found the solution. We have to go do PSA testing, get all these men with early prostate cancer, do a radical prostatectomy on them, and then we're reducing mortality. And then we worked with a very smart epidemiologist who was in Bristol, now is in York, Steve Oliver, and other colleagues in Bristol. And we looked at the mortality at the same time in England. And much to our surprise, we found that mortality from prostate cancer is coming down exactly at the same time as it's coming down in the US. Not at the same rate, but it is coming down. And I can tell you that in 1991, 1992, the total number of radical prostatectomies performed in England was 31 or 32, all performed by Neil Donoghue in London, and that was it. Now we're doing 5,000 or 6,000, but there is no way that this reduction in mortality could be explained by these very small number of radical prostatectomies which were done at the time. So what is it that's causing the mortality to come down? Well, it's got to be differences in lifestyle, it's got to be environmental factors, it's got to be genetic factors, and also it's got to be the fact that we have improved our treatment of locally advanced disease considerably with some very powerful combination of treatments to improve outcomes. So the evidence from epidemiology in a nutshell is that it is common in the West. There's an underlying rate which is fairly stable. There are different rates of mortalities which cannot be explained alone by screening or treatment. There's an increase in formerly low-risk countries. In Japan, for example, it's going up at the same time as meat consumption is going up in Japan, and that is fascinating. It increases in migrants, but some ethnic differences remain, and there are both genetic and environmental risk factors which we know are very important. So until recently, two words have emerged, and it's taken about 20 years for these words to emerge. One of them is over-detection, and the other is over-treatment. How can you over-detect a cancer, and how can you over-treat a cancer? So we know there is a significant risk of over-detection because it means detecting cancer in a man who would never have presented clinically or would not have suffered from that disease. And what we are actually doing is we're putting the label of cancer on that man without knowing that that he's at risk even of suffering the harms. And significant risk of over-treatment. So these figures still apply. If you take 1 million asymptomatic men who agree to receive a PSA test, 100,000 will receive biopsies, 20,000 will have cancer, 10,000 may receive radical prostatectomy, of those 10 will die. 300 will have some degree of incontinence, and 4,000 will have erectile dysfunction. Now, in the absence of evidence, it doesn't mean the evidence is not there, but we need to at least inform the patient of the uncertainties behind it. And there has been a profound lack of high-level evidence that aggressive treatment of screen-detected disease through PSA testing improves survival and quality of life. And I've been using this slide for a long time, until March 2009, where I had to put a cross on that statement. Why? Because the first results of the European randomized screening study on prostate cancer was published in the New England Journal, and that was in 2009. And in fact, in the same issue, another study from the US was published, and they showed completely opposite, different results, which was very strange. But we'll go in a little depth into why these two studies, which were published together in the same issue of that journal, failed to show the same results. And today, we have had an update on the European randomized study, which has just appeared in the New England Journal this morning, 11-year follow-up, and it continues to show the same trend. So we'll spend a few minutes on these two studies. The European study started in 1993. It was a randomized controlled study of screening. So essentially, you take the population, you split it in half, pre-consent randomization, half are going to be screened, the other half are not going to be screened, and then you find out who dies of prostate cancer, what is the overall mortality, you look at quality of life, etc. So it's not a study of treatment, it is a study of screening. The age range was 55 to 69. There was a 9-year median follow-up reported in 2009. And you can see the differences in death between the screen group, 72,000, control group, 89,000. And screening intervals were at 4 years with a PSA threshold of 3. And I'll show you the differences, but the differences in mortality, disease-specific mortality, was significantly, statistically significant, with a 20% relative risk reduction. The PLCO US study was similar. It was based in the US, men aged 55 to 74, and they had less in the arms, 38,000 screened, 38,000 controls, but the big problems they've had which is completely plaguing their study, is that more than half the patients, or half the men in the control arm, were contaminated. Contaminated by what? By PSA testing. So the control arm, which should not have received the PSA test, the men took themselves to their primary physician and asked for the test. And obviously, that made a huge difference to the power of the study. They showed no differences, and they have published an update now, 13 years on, with still no differences. And the simple conclusion of that study is that it was underpowered, reported prematurely, in which half the participants were screened before being recruited. And it was never a study of screening versus no screening. And even the investigators recognize that now. It was a study of intensive screening versus less intensive screening. And it is certainly my view and the view of others that this study will never be able to have sufficient power to show differences. The European study, on the other hand, did show a difference. And in real terms, this was a risk reduction of dying from prostate cancer of about 20%, which means that to prevent one prostate cancer death, you have to screen 1,400 men, and you had to treat 48, or you had to manage 48, not necessarily treat, because many of these will be receiving active surveillance. There was a substantial risk reduction for metastatic disease. You needed to treat 24 men in order to reduce the incidence of metastatic disease in one patient with prostate cancer. If you compare these figures with breast cancer, they're not a million miles away, except that the conception of overtreatment in breast cancer is much less than in prostate cancer, except for DCIS, which is now being also investigated. Now, on top of that, the Swedish arm of the European study reported separately in 2010 their own cohort in northern Sweden. They started first, and then they joined the European study. And much to everybody's surprise, they showed a substantially more favorable results towards screening. And the relative reduction in mortality was 44%, and you needed to treat 12 men only, and you needed to screen just under 300 men. And before we jump to conclusion and say, well, should that not mean that we should go out and screen everybody with such powerful figures? And the answer is probably not, because if you look at the absolute reduction in mortality from the prostate cancer screening study from northern Sweden, this is what you get. I don't know if you can see very well from where you're sitting, but this is a grid with lots of small grey squares. And there are exactly 5 dark red squares and others which are 4 dark squares and 5 see-through red squares. This is the total number of men that you would screen for prostate cancer. The dark red ones are the ones who will die of prostate cancer, irrespective of whether you screen them or not, because they have bad disease. And the ones that you prevent from dying are exactly 5. So if you look at the numbers, for 1,000 men at 14 years, 4 will die irrespective of screening, 5 will be prevented from dying, and 91 men will not die of prostate cancer. Now, this is the update study showing a continuing effect, and that the effect is particularly marked in the age group 55 to 59. This is the very recent study which was published today, and the bottom line is that at 11 years follow-up, as opposed to 9-year follow-up, the numbers needed to treat have now come down from 48 to 37, and the numbers needed to screen have come down from 1,400 to approximately 1,000. Now, are these figures still acceptable to introduce screening for prostate cancer? I don't think they are. I don't think NICE will jump on this. I don't think the Department of Health will jump on this to introduce screening for prostate cancer. There is still massive overtreatment. So there are 2 phases to PSA testing. Yes, Undoubtedly, screening can save lives, but there is a massive cost, and the cost is over-detection and over-treatment. And we don't know the exact impact of over-detection. We know what the impact of over-treatment is, and that is the morbidity related to treatment, whether it's surgery or radiotherapy, or even active surveillance with anxiety generated for the patient. So usually guidelines are driven by evidence. In prostate cancer, unfortunately, they are driven by lack of evidence. And if you can see here from very eminent organizations, sometimes within the same country, there are differences. Some advocate screening, others don't. The US task force have published a consultation document with recommendations against screening for prostate cancer, which were published in October. This is not the definitive version, and they are still receiving comments on that. And they asked these some very pertinent questions about the benefits and the harms of prostate cancer screening, and looked at the evidence which is available. And surprise, surprise, the evidence is extremely thin, and they ended up measuring 3 or 4 or 5 studies at most, which are providing some mature and some evidence which is still missing. This was the final recommendation, that the harms appear to outweigh the benefits, and they recommended that men should not be screened at the moment, and it's caused an uproar in the US. And I think it's probably too negative an attitude towards it, because men should be given the evidence and then decide for themselves whether the uncertainty in their own mind is worthy of PSA testing, with all the consequences of possibly ending on an operation table because they have been diagnosed with early prostate cancer. So if we had to summarize the pros and cons of the evidence that we have, is there improved survival? Yes, we have high-level evidence that there is, and with time the curves seem to separate, the Kaplan-Meier curves, and the number needed to screen and the number needed to treat are coming down. Is there an improved quality of life? That's still to be reported, and we're waiting for reports on quality of life from the European study. Is there a stage migration? Yes, absolutely. The cancer cases that we see now are not what we used to see when I was a registrar. The tumors are smaller, the volume is smaller, and many of them are not going to cause harm. We know that. Do we have the ability to determine risk by PSA baseline or kinetics? Yes, there is emerging evidence. Can we identify low-risk disease? Yes, but there is an overlap. So some patients where we think there is low-risk disease will advance and progress, and vice versa. The cons is that there is very definite over-detection, there is very definite over-treatment. We know the morbidity and complications from treatment. We know the cost to health providers. If the UK engaged in prostate cancer screening tomorrow, it would cost the NHS approximately 450 million a year. And that would have to come from elsewhere. The ability to maintain patients with low-risk disease in a window of curability under surveillance is a difficult matter, and it generates a lot of anxiety. It's being studied. We have a lot of interest in doing research to find out what is the best protocol, but it is imperfect and the evidence is limited. And there is reduction in prostate cancer mortality in some countries, which is not related to screening. And I want to illustrate all this with a case. So Mr. Smith is a lawyer. He's 68, he's asymptomatic, very successful, very rich. He's married to also a very successful and busy lawyer, and he has a girlfriend, that's his secretary, who's 25 years. And he receives a PSA test without counseling. So he goes to one of these well-known clinics, he's insured, and they do the PSA without even telling him. And then the PSA comes back as 3.2. His digital rectal examination is unremarkable. He gets roped into having 12 biopsies, and 2 of these biopsies show 2 millimeters of cancer with a Gleason 3 + 3 = 6, which puts him, according to the classification of risk in prostate cancer, comfortably in the low-risk category, particularly that he's also 68, so over the 65 threshold, which becomes the doubtful tranche whether screening and treatment of early disease makes a difference to mortality. So his choices are, as given by his treating clinician, either to have radical prostatectomy, radiotherapy, brachytherapy, or active monitoring. And of course, he goes to a wonderful colleague who has the Da Vinci robot and who tells him how wonderful this is, and he's done hundreds of cases, and it's even good for his sex life because it will restore his erections if he hasn't got them. So all the counseling goes on, and of course the patient chooses to have a robot-assisted laparoscopic radical prostatectomy. Strangely, he is found to have extracapsular disease, so there's tumor. The tumor is not organ confined, but the margins are negative, which is excellent, and the Gleason is confirmed as 3+3. So a little unusual to have a low Gleason and extracapsular tumor, but this is what he has. Post-operatively, his PSA is excellent, less than 0.1, but he's leaking a little bit, so the robot hasn't worked as well as it does. He should have come to Oxford, but there we are. He's wearing 3 pads, and he's got erectile dysfunction. So here, this is the next step. Cancer is out, margins are negative, markers are good, everybody's happy, but not quite, because he's leaking and he can't have intercourse. So these are his options: observation, adjuvant therapy with hormones, radiotherapy because of the positive margins, have some medication for his erectile dysfunction, or have an artificial sphincter for his incontinence. So he elects to have observation and to receive Viagra, and things seem to be okay. 3 years later, his PSA starts to rise and is generating a lot of anxiety. He suffers a myocardial infarction. He's now 71. His wife leaves him, and he marries his secretary, who is 28. And Viagra, unfortunately, is no longer working, so it is a problem. And these are his options. More observation, change his medication, take hormones, try to find whether there is more disease and relapse and do biopsies, or do a PET scan to try and find out residual or relapsing disease. He stays on the conservative side. He selects another medication for his erectile function. 1 year later, he's 72. He gets acute low back pain during sexual activity, and he gets an isotope bone scan which shows a hot spot in his vertebra. His PSA is 0.2 nanogram per mil. These are his options. We're on to the 4th stage of his management now. Observation and simple analgesia, bisphosphonates to protect his skeleton, anti-androgens, or change partner. So what he chooses is hormones because he is told he has metastatic disease. So he receives androgen suppression, and he bobs along, and 3 years later, he has persistent low back pain. He is now 74, and he's got a pathological fracture, and it's not metastatic disease. So this patient received androgen suppression inappropriately. He probably was osteopenic at that time. Nobody looked at his skeleton, and his osteopenia became osteoporosis because of the androgen suppression, and he developed an osteoporotic fracture. This is tragic. No libido. His new wife leaves him. This is the credit crunch, so he loses 60% of his financial assets invested in Iceland, and these are his final options. And of course, the answer is all of the above. And 1 year later, sadly, he dies of another heart attack. And the question here is, did this patient deserve to be screened and treated? And I'll let you think of the answer. But equally, I could show you a case with high-risk disease in a young man who's picked up early, who is treated, and who survives 10 years or more cured from his disease. So there are two sides of the story. It's not all negative. It's not all positive. And the challenges ahead are that we really need to continue to interpret intelligently the studies of screening and we need to await the treatment effectiveness studies, which I'm going to mention now towards the end of my talk. We need to reduce over-detection. We really have a responsibility for that. And we need to minimize over-treatment, which can cause all these series of events in a patient who was otherwise healthy and happy. We need to educate physicians and public, develop algorithms to identify low-risk disease, discover novel biomarkers. And there's a flurry of activity in the labs worldwide trying to find new biomarkers and risk calculators. And of course, genetics are there to help us. At the moment, genetics and single nucleotide polymorphism are only helping us to place patients in pigeonholes, whether they are at risk of having cancer. We still want to find a panel of genes or SNPs which tell us whether the disease is significant or not, and we do not have this yet. So let's spend a few minutes on treatment. What is the ideal treatment for any condition? Well, it has to cure everybody, is given as an outpatient, has no side effects, and costs nothing. But like the ideal husband or the ideal wife, the ideal treatment does not exist. Otherwise, the NHS would not be where it is today. In the 1990s, radical surgery was the gold standard. Radiotherapy was given to patients that the surgeons did not want to operate on, and watchful waiting was for the older man, where he had a tap on his shoulder, sent away, and told to come back if he had symptoms. Now things have changed dramatically. I mentioned to you earlier the radical prostatectomy numbers in the UK, and here they are, 1991, 36 cases. Now we are well in excess of 6,000, and of course one of the reasons is the very widespread of the Da Vinci robot, and we're very fortunate to have. It is a wonderful piece of equipment, but it is an instrument. It is a very sophisticated instrument to do very expensive surgery, and the more important thing is to know when to use it rather than to use it all the time. So why is it that we are putting patients through surgery despite all the uncertainties that I've mentioned to you before? And I've searched this for a long time and found the answer, and the answer is in what we call the surgical imperative. What does it say? It says that if a surgeon tells you that without an operation you will die, as a result of the operation you may die, you have no choice but to have the operation. And when you think about what we tell our patients in clinic and how we get them to undergo prostatectomy for right or wrong reasons, whatever, this is what we tell them. What's interesting is to find out who actually said that. And it is absolutely true. So we say that we treat patients with early prostate cancer because we improve their survival and we prevent them from dying of prostate cancer. And then I asked myself, what is the meaning of life, without going into deep theology or philosophy? And this is the best definition I found, is that it is a sexually transmitted condition with 100% mortality. So even if we cure all men from prostate cancer, they're still going to die. And then I said, okay, we also say that we improve men's quality of life. And the question that very few people ask is, this is a prostate, having been taken out very elegantly with the robot. Is the quality of life better for the patient or for the surgeon? And very often it is the latter. We are very particular about the operation of radical prostatectomy. We learn it very meticulously. We travel all over the world to see others. We bring people to come and show us how to do it. We're very proud of the results. It's usually done extraperitoneally or now robotically intra or extraperitoneally. The patients recover extremely well. In my unit, patients come the day of the surgery and they go home lunchtime the next day and then back on their normal activities within 2 to 3 weeks. So really the surgery has improved considerably. But there are things in life which you should not believe, and one of them is when colleagues say you have no complications, which is not entirely true. So what research happened in the 1990s? There was the Scandinavian study comparing watchful waiting with radical prostatectomy in Sweden. There was a systematic review of the literature in 1996, There was a failed MRC study in the 80s, which closed in the early 90s because they could not recruit, comparing watchful waiting with surgery and radiotherapy. And there's the European study which I've mentioned. There was an equivalent US study which has just been reported. There were opportunities in the UK. And this is where, if you're in the right place at the right time and you have the right idea, you actually are very lucky. And we were very lucky. So in 1996, Health Technology Assessment of the R&D department of the NHS, which is now NIHR, commissioned 2 systematic reviews on screening and treatment of prostate cancer. And the recommendations of these reviews were that there was insufficient evidence to suggest benefits of screening, and that randomized controlled trials of screening and treatment had to be conducted. HTA put out a call in 1997 for primary research project, and we put exactly at the same time, in 1997, 2 linked proposals, one for a feasibility study of PSA testing and randomized treatment between surgery, radiotherapy, and active monitoring, to be followed by a main trial of a classical RCT. And the reason we've done a feasibility is that we knew that no one would fund a large study unless we could show that you could detect cancer in a young, healthy man and then randomize him to a non-intervention arm. There was huge skepticism because the MRC trial had failed. So both grants were submitted simultaneously in December 1997, and in June 1998, the feasibility grant was awarded, and the main trial was kept on hold, pending results of the feasibility. Now, this is 1 year into the trial, 1 day before the monitoring visit from HTA to tell us whether we would continue or stop. And after a year, we had recruited 22 men in 3 centers, which was not very good. 5 had agreed to be randomized, 5 were thinking about it, and 7 chose their own treatment and didn't want to hear anything about randomization. So we had in the 2 arms, forget the 3-arm was intervention versus watchful or active monitoring versus surgery, radiotherapy, and the other one was taking out active monitoring completely. And we had in the 3-arm 1 patient randomized to surgery, 2 patients randomized to radiotherapy. And I was looking at these data with my colleagues, investigators. It was Jenny Donovan at the time in a small, cheap hotel in Bristol. And we said, we are dead. This is not going to work. And tomorrow, HTA are going to close the study. And much to our surprise, we did present all these data. But what they liked in what we were doing is the fact that we were trying to understand the patient perception. Why is it that a patient accepts to be randomized and a patient refuses to be randomized? And because of this qualitative research, they allowed us to continue for a year. And they give us additional funding to do it. And what happened within that year is that one of the 3 centers, and I won't tell you which one it was, I was in Sheffield at the time, but it wasn't Newcastle or Bristol, but one of the centers was randomizing 95% of the patients, and the others were randomizing 20 to 30%. And we didn't know why, and Jenny called me to say, look, we have a problem. You're randomizing so many men, and the others aren't. What is it that you're doing? Are you coercing them? And I said, no, I'm not coercing them. I talked to them honestly about the uncertainties. And she asked me to write down what I was telling them, which is what we did. We transcribed this. We introduced training for the other recruiters. And that was the breakthrough, because in August 2000, we went up to 45 men eligible. And by the end of the feasibility, which was May 2001, 155 men were eligible, of whom 70% were randomized, and of those 70% agreed to receive the allocation from the randomization. This was to the 3-arm. So that was the breakthrough. And what this has done with HTA and other funding bodies is that they will not now fund large studies without pilots and without feasibilities, because the risk is too great, and it gives confidence to the conduct of the main trial. So again, we were very, very lucky, and it was largely thanks to high-powered qualitative research, and I'm very grateful to my colleagues in Bristol for initiating this very systematic way of understanding patients' perceptions. We came up with 3 big lessons. First one is that large clinical trials must be embedded in qualitative research to understand perceptions from patients and from recruiters. Equipoise is a word which I've learned on the job, so to speak. If you say something and your body language says something else to the patient, they will pick up your body language, not what you say. So you have to have an internal equipoise about the treatments that you are offering to the patient in terms of randomization before you are able to engage him into being randomized. And research nurses are wonderful. I would not do, again, any large clinical trial without the engagement of research nurses to actually recruit the patients. And this is because doctors are biased. We've shown that over and over. The surgeon will offer in preference surgery, the radiotherapist will offer radiotherapy, etc. And one of the methodology papers that we published says this: it's not just what you say, it's how you say it. So the milestones were there. In 1999, the government was spending something around £100,000 on prostate cancer research. When they decided to fund our main trial, they put 13 million on the table, and now this totals, with the extensions over the last 12 years, 34 million for a single study, which is unheard of even by US standards. Now, why did men take part? For many reasons. Some said that it was testing, it was perceived to be a good idea to help with research, and they had other motives, and this is one of the most interesting ones. Louise was one of our wonderful research nurses. She's still there. She's in Sheffield, worked with us for the last 12 years, and this was on one of the envelopes from the patient who wrote, sent back his survey questionnaire saying, "Louise, I can't sleep, test me again." This is Louise, and that's her mobile number. So this has led into what the PROTECT study is, which John was alluding earlier. It is now the largest randomized controlled trial of treatment effectiveness in screen-detected prostate cancer worldwide. It is the largest trial, and it is a flagship for NIHR and for the UK. The design, as I said, I mentioned the pilot. The main trial is a classical RCT comparing active monitoring with surgery, with radiotherapy, with an endpoint of disease-specific mortality at 10 years. We've closed recruitment in December 2008, and these are the numbers. We tested in 9 clinical centers, 111,000 men. Of those, 60 of the ones that were eligible with clinically localized disease, 63% were randomized to one of 3 arms. And what's interesting is of the men who chose their own treatments, the majority chose active monitoring, and that is because of the quality of the counseling and the unbiased and approach and the equipoise in the minds of the recruiters. So we now have the largest cohort of men where we are studying the natural history of untreated prostate cancer. Apart from the treatment effectiveness study, what we were doing is, in each of the 9 cities of the UK, is do a pre-consent randomization of the GP practices, so that one would receive screening through PROTECT and the other would not. And this was essential for the statistical power. So the Department of Health and CRUK came back to us and said, well, look, could you study screening as well as treatment? And there was a natural control arm which was there, which we are now using as the comparative arm of the PROTECT study. So PROTECT has become the intervention arm of the largest cluster randomized study of screening, which with larger numbers than the European study. This proves the point of the Scandinavian trial comparing surgery with watchful waiting, where they looked at quality of life. And what they did, this was only just published, what they did is they took a cohort of men without the diagnosis of cancer, age-matched, the men who received surgery and the men who received watchful waiting, and they compared them. And what they show is that undoubtedly the sheer diagnosis of prostate cancer reduces your quality of life, irrespective of whether you receive surgery or watchful waiting, compared with men who do not have the diagnosis of cancer. These are the best results of the Scandinavian study, showing differences, reductions in mortality, disease-specific, overall, progression to metastatic disease, all positive. And the most recent data suggest a threshold of around 65 years, where beyond that, you are unlikely to get any benefit from being treated for prostate cancer. And we have to remember that these cohorts are non-screened men, so they are much further on the right side of the stage migration shift. PIVOT is the equivalent US study, which is not reported in a publication yet. It was presented at the American Urological Association and this year in the European Association Congress meeting, and it shows no benefits for low-risk and intermediate-risk disease for surgery. Now, I want to finish, if I may, just with opportunities which have arisen from this very large study. And this is the translational opportunities for doing add-on research from the data we've generated in 100,000 men who were screened, the biomaterial that we have been collecting very religiously. And we now have over 55 linked studies in various areas of epidemiology, genetics, proteomics, collaboration with the US and collaboration with Europe, which have been wonderful. We have contributed to the first genome-wide association study, where new loci of risk association prostate cancer were found. One particular gene in familial prostate cancer has now translated into an assay, and this is being evaluated now in our Protect Men, driven by the Cambridge group, showing that MSMB in tissue and urine and serum expression is reduced in the presence of prostate cancer, and this could become a new marker of the disease. We have also determined whether patients are suitable for focal therapy of prostate cancer, and we found that it was 20% or less, and we have published that recently. So when are there going to be outcomes from that study? Well, in 2008, when we closed recruitment, median follow-up was 3 years, so certainly insufficient. 2 years ago, 2010, median follow-up was 5 years, still insufficient because prostate cancer grows slowly. 2015 is our first formal analysis. There will be an average 10-year follow-up. We may not have enough events at the time, but we will unblind the data. That's in 3 years' time. 2020 will have a median follow-up of 15 years, which will be much more powerful. This will be the second and final analysis. In 2025, I'm planning to retire, and I have already quite a few ideas in mind about what to do and where to go. I want to thank the huge team of collaborator investigators across the country. What you can see here in the front row, you can see Michael Baum, who will be known to you, Professor Emeritus of Surgery at UCL, who chairs our trial steering committee. You can see Jenny Donovan here from Bristol. You can see David Neal, and you can see Athene Lane, our trial coordinator. And the majority of the people in the back are people employed through the study full-time. The oldest member of the team, well, I don't mean oldest in years, but has been employed throughout the study for the last 12 years and continues to be employed, and his name is Pete Holding. He's from Sheffield. This is the Nuffield Department of Surgical Sciences. I'm extremely proud to be head of that department. And there's something which struck me when I was in Newcastle. David Carter came to visit from Scotland, and he produced a picture like that. And in the picture that he produced, he was sitting proudly in the middle, but he was the only guy smiling, and all the others were not. And I pride myself by finding smiles in all the rows, because this is a happy department, and I'll leave you with the dreaming spires of Oxford. Thank you very much for listening.
you very much, Freddie. I wonder if I could ask Mike Bishop to propose a vote of thanks. And after that, Helen Percival's just got one other thing to consult the audience about, which is not to do with prostate cancer, if you don't mind. Mike.
Well, Freddie, I hardly need to remind you, is becoming a national treasure to us urologists. And I hope that, like all of us, you'll be impressed, you will have been impressed by his humility, his wisdom, and the ability to put over a really difficult topic and to give us the facts, and without being too biased about the conclusions. Isn't it a pity, after so many years, that Jeff Chisholm's predictions really have come to pass? And I love this term, prostatectomy holocaust. Last year in Hamburg, which is an average-size German city, one hospital amongst quite a few hospitals did nearly 400 radical prostatectomies. And after this wonderful lecture of Freddie's, we can, I think, work out how many of those will have had their lives saved by this operation, and how many of them will be incontinent and impotent, arguably needlessly. We've heard that there have been a number of trials in the US and in Europe, and they've been well conducted and with huge numbers of patients and very energetically and by very worthy people. And the answer is not clear. And the GPs amongst you acting as advocates for your patients will, I think, have great difficulty in achieving a take-home message from this talk, and that's certainly not Freddie's fault. What I do think is that there is room for another trial, and this is a very, very good trial being done in England. It's being very well conducted, and I think that there will be new information which will inform the way that people with men with localized prostate cancer are treated. What a pity it takes so long, and I was reminded really of that rather nice picture of the gargoyle, the poor tragic man gazing down, as he has done for 500 years, with this terribly sad expression on his face. It sort of reminds me of the medieval stonemasons who, when they were putting up a cathedral, there'd probably be 4 generations of them who would come and go before actually the cathedral rose up. And I kind of feel the Prostate trial is going to be a little bit like this. And I think Freddie does as well. That lovely slide at the end, really, his retirement party. And if he's lucky, he'll be able to give more lectures with very firm conclusion. But I kind of doubt it, and I think little bits of information will be leaked, but it'll be good information. And Freddie, I do hope that you do live long enough, or at least that you remain in work long enough to see the fruits of this wonderful and energetic piece of work. So thank you very much, Freddie. It was a wonderful talk, and I think we should express our appreciation the usual way.